Hello, everyone. My name is Dr. Ari Isaacson, and I am presenting this webinar to you today on behalf of IR Centers and the Associated Urologists of North Carolina. And I thank you for joining us and spending some of your evening with us. I'm going to talk today about prostatic artery embolization as a newer treatment for BPH or enlarged prostate. So first, just a little bit about my background. I went to medical school in Los Angeles at the University of Southern California. And afterwards, I joined the Navy and spent several years in the Navy as a flight surgeon. I then returned to my medical training at UNC here in Chapel Hill. And I did my residency and my fellowship. Now, I'm not a urologist. The kind of doctor that I am is an interventional radiologist, and I'll get into what that means in just a sec. But after I finished my training, I stayed on staff at UNC for 8 years. And I did a lot of research. And one of the procedures that I researched when I was early on in my career was this prostatic artery embolization. In fact, I was the second physician in the United States to run a trial on this procedure. And so that's how I got started in it. And I'm still doing it 10 years later. I'm still here doing this procedure. So what we're going to talk about today is a little bit about BPH, or benign prostatic hyperplasia. And then I'm going to go into the procedure itself, prostatic artery embolization. We'll talk about how it's performed, and then we'll get into some questions that usually people have about it. So first, what is an interventional radiologist, and why am I not a urologist? So interventional radiology is a little bit difficult. We always joke we have really bad PR, that no one really knows what we do. But we're trained initially as diagnostic radiologists who read studies. And then we go on to have additional training that allows us to do minimally invasive procedures that use some sort of imaging to guide the procedure. And so a lot of those procedures have to do with working in the arteries and in the veins, just like cardiologists do catheter procedures. We do procedures with catheters also, just not in the heart, and pretty much every other place besides the heart. That's the kind of stuff that we do. And so at IR Centers, which is the facility I work at, we work with the urologists of AUNC, and it allows us to provide very convenient and efficient type of care for patients that go to see urologists at AUNC. All right, so let's get into the procedure a little bit. Or first, let's talk about BPH. So what is BPH? A lot of people always ask me this, especially patients. They're like, why? They say to me, why is it that my prostate is growing? Is there anything I can do about it? And so the answer is we really don't know exactly why the prostate grows as men age. We do know it has to do with a few things. So one big component is genetics. That usually, if if you knew your father had problems with this, it's likely you will as well. And if you have a son, you can warn him as well that there's a strong genetic component. Additionally, we know hormones play a role, testosterone, but not necessarily. It's not a very simple thing. It's not like if you have more testosterone, you have a bigger prostate. That's not how it works. And it's not also if you take testosterone, if you're being treated with testosterone, that doesn't mean that makes your prostate grow either. So it doesn't have that relationship. But we do know hormones play a role. And then the other thing that likely plays a role in it is just general inflammation. The more inflammation tends to cause the prostate to grow as well. And when the prostate grows, men will experience a certain number of urinary symptoms, which I'm sure if you're listening and you have this issue, you already know what I'm gonna say. But those symptoms are split into two categories. There's storage symptoms and there's voiding symptoms. So the voiding symptoms are the ones that are a little more, I think, intuitive. That your stream is weak when you urinate. That it's hard to get started, that you might start and stop in the middle of your urination. And those make sense because you have a prostate that's kind of squeezing the tube where the urine's coming out. The storage symptoms are a little harder to explain, but what they result from irritation. And what's happening is the prostate growing is irritating the bladder, or the bottom of the bladder. And when the prostate does that, then you have the urge to go often. It makes you want to urinate frequently. You also may have this feeling that you need to urinate right away. When the feeling comes on, you have to run to the bathroom, or you might have an accident. Also, the getting up at night, getting up 2, 3, 4, up to, people have told me to get up 6, 7 times sometimes a night. That is also from the enlarged prostate irritating the bladder. So all those things can happen from enlarged prostate. All right, so why is this important? Well, it's important because it happens to a lot of people, and not only does it happen to a lot of people, this has been treated for a long time with surgery, and although that surgery is very effective, it does tend to have a lot of side effects. And so over the years, both urologists and interventional radiologists have come up with alternative procedures that would help with enlarged prostate that don't necessarily have those same side effects. The other thing to note is that the first line treatment for enlarged prostate is medication, and I'm sure a lot of you are on those medications like Flomax or tamsulosin or alfuzosin or finasteride or dutasteride. And those are helpful, but they also tend to have side effects, and that's another issue that we face. So let's talk a little bit about some of the procedures that are available for enlarged prostate. One you may have heard of is Urolift, okay, and that's in that procedure, and I'll show a video of it in just a second. That's where the prostate is actually being displaced to the sides to make room for the tube down the middle. There's prostatic artery embolization, which is what I do, and we'll talk more about that in a second. There's the Rezūm procedure, which uses hot water vapor or steam to kind of destroy part of the prostate. And then there's aquablation, which uses a very powerful water jet to also destroy part of the prostate. So let's look at some of these videos. So why don't we start with the top left video, and we can show the Urolift here. So this is a video of what happens with Urolift. There's a camera that's inserted into the penis, and then this instrument is used to displace the prostate to the side, and then a suture is shot out of it, and it wraps around and anchors on the other side, and it compresses the prostate. So when you're done, you can see how there's a wider space in the middle, and so that's Urolift. All right, let's go to the one on the top right now. This is Rezūm. So again, camera through the penis, instrument through the penis, and here's this little spout that comes out, and it shoots this hot water vapor, which then destroys the prostate tissue, and that also allows there to be more room to urinate and reduces some of the symptoms of irritating the bladder as well. There you go. So you can see how it gets smaller over time, over that 1 to 3 months. All right, and then finally, let's do the bottom left, and this is going to be aquablation. So this might be a little much for some people. I don't know. I think, but anyhow, the patient is sleeping when this happens. A ultrasound probe is inserted in the rectum, and that allows the surgeon to see the prostate, and then the instrument is inserted through the penis. When this instrument goes in through the penis, the machine itself does this automatically. Okay, go to the final video, please. And you can see what's happening here. So this high-powered water jet is basically destroying the prostate tissue that has been marked by the urologist. Okay, we can go back to the slides now. So that's kind of an example of other possible procedures. Those are newer procedures that have been recently invented in the last 15 years or so to treat the same problem. Now, I want to get to this point. I want to get to prostatic artery embolization, or what we do, a PAE. And when I guess first, let me just, talk about what the word embolization is. Let's see. Okay, got it. So embolization is the word for blocking the blood supply to a target on purpose. So you may have heard of a pulmonary embolism or something like that. That's different. That's a blood clot that goes to the lung. In an embolization, we're actually purposefully blocking the blood to a very specific area. And so in this case, we're blocking the blood specifically to the prostate. And by doing that, we starve the prostate of oxygen, and the tissue in the prostate, some of it, not all of it, tends to die, and those dead cells then get replaced by scar tissue. And ultimately, the result is that the prostate will reduce in volume anywhere between 20 and 40%. And not only will it reduce in volume, it'll also soften. And so when it softens, it allows the urine to come out easier, and also the bladder is less irritated. So we get a combination of improved obstructive symptoms and irritative symptoms. So what I want to do here, let's play this video here. So this is kind of a computer-generated animation of what happens during prostatic artery embolization. A very small tube gets put through the arteries, and then we guide it down to the artery that is specifically supplying blood to the prostate, and then we inject these tiny particles that block off the blood supply to it, and that's how we get the prostate to shrink. You can see that little picture on the right is actually a dog prostate, and on the image on the left is what the enlarged prostate looks like when the dog has BPH, and then the prostate on the right is what happens after we do the embolization. You can see how it shrinks quite a bit. All right, this is what we see on the X-ray imaging when we're doing the procedure. So this video kind of runs through a PAE or case and shows what we see. So let's go ahead and run this video. So we inject contrast dye. That's what makes the arteries look dark. So what you're seeing there are arteries in the pelvis. And so that creates a map. That's how we know where to guide the catheter. And so once we have the map, we insert a smaller catheter, what's called a microcatheter, and we get to the specific artery that we know supplies blood to the prostate. You can see it's that very curvy one at the bottom. Once the catheter is in place there, we inject more contrast dye so that we can see the prostate itself, and that's what you're seeing right now on the screen is the very large prostate. And once we've identified it, then we inject these particles that are mixed with the contrast dye, and that shows us that we can see the particles on the screen. Let's run it one more time. Let's just run it through one more time, so we can see it. And again, so just to tell you what we're seeing again. Contrast injection under X-ray to show where we need to go to create a map, and then the small catheter is inserted with a wire that has a little curve on it. That's how we steer it, and we are able to get into the specific artery that we want. And then once we're in the artery that's only supplying blood to the prostate, we inject the particles that block the blood to the prostate. So we don't want to block the blood to anything else like the rectum or the bladder or the penis. We just want to block blood to the prostate. And so that's what we're doing right here. And when we're done with the procedure, you no longer see blood flow down to the prostate. Okay, we can go back to the slides now. Okay, and let's see. Next slide. Oh, I guess I do that. All right. What about recovery? So a little bit, let me step back a little bit about the procedure. The procedure is it's not painful. Okay. So because it's not painful, we don't do it in a hospital. We do it in an outpatient facility, and we don't put patients to sleep for it. We do offer Valium prior to the procedure to help anyone who's nervous about it. But patients are awake. Now, before we insert the catheter, we insert it in the groin area, in the femoral artery, and we numb up the skin there before we insert it. So there is a little bit of a bee sting when we numb it, but after that, patients don't feel anything. And a lot of people don't realize this, that you don't have any nerves inside your arteries. So we can insert the catheter in the arteries and you really don't feel anything at all. When we inject the contrast dye, there is a little bit of feeling of warmth that people will feel. And then also when there's a time when we'll inject a medication and there'll be a little bit of a burning sensation. And we warn you about that when you're there, so it's not a surprise. But all in all, there's no sharp pain during the procedure. The procedure usually takes about 30 to 40 minutes to do. And then when we're done, we use a closure device to close the artery so that it doesn't bleed. And then patients recover for 90 minutes. During that 90-minute period, we need patients to lie flat and keep their right leg from bending. And that's just because that device that we put in to close the artery, we don't want it to be displaced so that it leaks. We want it to set right where it is. If the Valium that we offer at the beginning of the procedure is optional, it's if you don't want to have the Valium, you can actually drive yourself home after the procedure. But if you do have the Valium, then you will need a driver. And then for recovery, the main thing we ask is that you don't lift anything heavier than 15 pounds for 3 days. And the reason for that, again, is we don't want to have that that patch, that device that we put in to stop the bleeding. We don't want that to be displaced. And so that's the main restriction. But other than that, the good thing about this procedure, we make it as easy as possible. You don't have to fast before the procedure. You don't have to stop your medications. You don't even have to stop your blood thinners. We keep patients on blood thinners for this. So we want you to do the exact normal thing that you do every day. Take your exact medications, eat as you normally do. And all you have to do is show up, and we'll take care of the procedure. And then afterwards, we just don't want you lifting anything heavy for 3 days. All right. So what does the recovery look like afterwards? So for a few days after the procedure, there will be kind of worse urination because of the inflammation we've caused in the prostate. And what does that look like? It kind of looks like, if anyone ever has experienced a urinary tract infection, it's very similar. So you're going to have even increased urination, more nighttime urination, more burning when you urinate. And those symptoms will be their worst the night after the procedure. So I warn every patient after the procedure that you're not going to get a ton of sleep that first night, and just to expect that. You're going to feel like you have to urinate very frequently. The following day, it should calm down quite a bit. And we do provide prescription medications for this afterwards to alleviate some of these symptoms so that it's easier. It usually takes anywhere from 3 to 7 days to get back to where you were before you did the procedure, so that things are back to baseline. And then starting at about 2 weeks or so, that's when patients start to notice improvement in their urination. And initially, that improvement is not drastic. It's subtle, and it's inconsistent. It doesn't happen all the time. But over time, as we move forward to 1 month to 6 weeks, those improvements will become more consistent and will be more pronounced. And so usually the whole process takes about 3 months to really get the full effect of the procedure. All right, so we're at a point where I'm going to answer some common questions. And then after I've answered those questions, I'm going to go to the questions that you're asking in the chat, and I'll go through those. Okay, so first question is the procedure painful? So as I mentioned earlier, it is not painful. We will numb up the skin prior to inserting the catheter. And once we do that, there's really only a warmth feeling when we inject the contrast and a little bit of a burning when we do a medication that we inject, but it's very short lasting. So there's nothing sharp or painful about the procedure. What are the risks? So the risks are, because it's a minimally invasive procedure, the risks are minimal. Some things that we do warn patients about are, it is possible to get blood in the urine or blood in the stool or blood in the semen after the procedure. And if those things occur, it's not worrisome. It will resolve on its own. One thing that can happen after the procedure is a little bit of the tissue on the inside of the prostate, where it compresses the urinary tube, can slough off. And so if that happens, there can be a little bit of blood in the urine. It can also potentially make the urination much worse for a short period of time. But usually that tissue will pass through the urine stream, and then things will get better. Additionally, you can get a hematoma. That's a collection of blood where we puncture the artery. That's not an emergency, but if that were to happen, we would ask patients to let us know, and we would manage it and make sure it goes away. Very rarely, in 1 in about 300 patients, we can see a penile or an ulcer on the penis form. Now, you may say, "Why? How could that happen?" Well, the arteries of the pelvis are more like a spider web than anything else. So there's a lot of connections between them. And it is possible for the particles, when we're injecting them into the prostate, to go through a connection to a different artery that goes down to the penis. And if they flow down to the penis, to the skin of the penis on the head of the penis can be starved of blood, and it's possible for there to be a sore. Now, first of all, that's very rare. It happens only in about 1 in 300. And my job when I'm doing the procedure is to make sure that doesn't happen. So I've done this procedure between 4,000 and 5,000 times over my career. And so that's a skill that I've learned over time as to how to prevent those type of complications. So it can happen, but it is very rare. If that sore were to develop, it would heal over time. It's not permanent. It tends to heal in anywhere from a few weeks to and the longest I've seen is 3 months. But Again, not permanent, a temporary thing, but it is painful for the time that it's there. And it only, again, happens very rarely in those patients. What about sexual side effects? Does this cause sexual side effects? The answer, for the most part, is no. In those 4,000 patients that I've treated, I've seen just a handful that have developed either lesser erections or reduced ejaculate. It can happen, but again, extremely rare. For the most part, this does not affect sexual function, and that's what separates it from some of the other procedures that are present for or are available for BPH. All right, do you have to go through the penis? Absolutely no. That's what separates me from urologists. I don't do anything through the penis right now. Will I be able to stop my prostate medications? That's a great question. I'd say 2/3 of patients end up stopping their prostate medications after the procedure. Usually, we don't do it immediately. So if you're taking something like tamsulosin or Flomax, we usually wait 6 weeks after the procedure to stop them because we want the procedure to work before we stop it. And so we don't want a patient to feel like they're worse off by stopping their medications early. Is PAE covered by insurance? Yes, for the most part it is. Very rarely do we have any issues. There are a few insurance companies that have some stipulations, but for the most part it is covered, and it's covered by Medicare, which tends to be the largest insurance company or I guess payer for our patient population. All right, what should I do to prepare for the procedure? Again, not a whole lot. Just make sure you show up. And the other thing is to pick up your prescriptions that we will send out before you come in, so you have them ready. So we'll prescribe them a few days before, and we'll ask that you pick them up prior to coming in. How long will it take before I notice improvement in symptoms? But usually about 2 to 3 weeks is what we see. And how long will that improvement last? That's a good question. I need to address that. The effect of this procedure does not last forever, unfortunately. It tends to last on average about 5 years. So what is average? Average is not the longest and not the shortest. It's what maybe most people, or if you took all the times and added them up and divided them, you'd get that number. So that means that for some people it's going to be longer. I've seen patients where the effect is lasting 10 years. But there's also patients who come back after 2 years and their symptoms are returning. For those patients, we usually will do the procedure again and get a longer lasting effect. So it is possible to repeat the procedure. I guess I'm jumping to the next question there. So the procedure is repeatable. The other thing to say is that having this procedure doesn't prevent patients from having any other procedure. So if you're on the fence about having one of those other ones that I spoke about earlier, you could have this first, see if it works for you, and if it doesn't, then you can move on to one of the more invasive procedures. When can I resume normal activities? So usually about 3 days. So a lot of patients ask, when can I play golf again? I usually say 3 days. The one thing that I will say for sexual activity, I tell patients to wait a week. I just think it's a little safer for the blood vessel to wait 1 week on sex, but everything else, with the exception of maybe powerlifting or lifting really heavy weights in the gym, I would say 3 days. Okay, so we got through all those questions. So and now at this point, I'm going to go to the questions in the chat. Let me just make sure we. Oh no, actually, let's pause on that for a second. I actually have a really nice short kind of documentary style video that shows what it's like to have the PAE procedure in our office. And I think, a lot of the challenge I have when I talk to patients before this procedure is to really convince them that it's really not as bad as they think it's going to be. I think anything associated with a urologic condition tends to bring up, kind of fears of pain and things going through the penis and all that. And this is quite different. And so I try to express that, but sometimes it's hard. So I think having a video would be helpful. So can we go ahead and play this video? It's about 8 minutes, so it's a little bit long, but when we're done with the video, I'll get to the questions, okay?
Hi, my name is Dr. Ari Isaacson, and I work at IR Centers Raleigh, and I perform prostatic artery embolization, or PAE. This video is meant to help you understand what it's like to get a PAE at our office. So please take a few minutes to watch the video, and I hope that it answers all of your questions.
actually going to send it to your email if that's okay.
I went to medical school at the University of Southern California. After I graduated, I served in the Navy for a few years, and then I ended up at radiology residency at the University of North Carolina. I stayed there for my interventional radiology fellowship, and when I completed that year, I was hired as an attending radiologist at the University of North Carolina. I practiced interventional radiology there for 8 years before I decided to come here and open up this practice, IR Centers Raleigh. The reason I made the decision to come here is because I wanted to have the opportunity to have a practice that really focused on patients, where patients could have convenient parking, walk in the door and feel like they're getting personal attention, see the doctor before and after the procedure and as much as they wished, and be able to contact the physician also if they wanted to call and ask a question, that they would get a call back from the doctor, which is, I hear, relatively rare these days. This practice allowed me to do that, as well as perform procedures that I really enjoy, which are embolization procedures, and specifically PAE, or prostatic artery embolization. Hey there. How you doing? I'm Dr. Isaacson. How are you?
All right.
Okay. Do you have any questions for me about what we're doing today?
What we do is, during your prep, what you can expect is that we'll bring you back. We start an IV, get you in your birthday suit, get you in a gown, get you some fun little grippy socks and some warm blankets, give you a couple pre-op medications, and give you Valium. If you're feeling nervous, that is optional. Dr. Isaacson will speak with you, as well answer any questions. If I didn't answer anything for you, he can do that. So he meets with you pretty quickly.
Okay, hello. Hello. How are you doing? Hi. I'm Dr. Isaacson. So our plan for today is
When patients arrive in our office, majority of our patients are nervous and anxious, and they don't really know what to expect coming in. We really like to inform our patients that there's no pain to be expected with this procedure, but they do also get to speak with the doctor before the procedure, and that tends to help calm their nerves, because he will then answer any questions that they have, and we can also go over the procedure again and recovery process.
So tell us why you like to go in and talk to the patient.
Yeah, so I think every patient wants to see their doctor before the procedure. It gives them an opportunity to ask any questions. It's also part of the consent process. So part of them giving consent to do the procedure is that they've had all their questions answered. So it's important that I give them the opportunity to ask any questions they have before they go in. And then what I really want to, the message I want to get across in the morning is just a message of encouragement that this is going to go well and you're in good hands and it's not going to be painful, and it's a good first step to changing the rest of your life.
Take you back during the procedure. We'll get you hooked up, get some vitals. That'll be monitored every 5 minutes. It's a little chilly back there, so we make sure we get you covered up with some blankets. One of the guys will usually shave your groin. They like to crack the joke that they're barbers. They're usually pretty funny, and they'll help keep your mind at ease as well.
How you doing, man? You doing all right? Good, yeah.
A lot of the emotions that the patients are having, it's on a very large spectrum. We have some that are calm, some that are nervous, and of course the nervousness comes from the unknown. So I just really try to bring them in and let them know that, we're all on the same page, and once they're in our hands, they're safe, they're good.
Coming to IR centers, you are going to definitely see that we do this all day, every day. So with us doing 4 to 6 cases a day, our cases tend to be 30 to 45 minutes long, so that's made us very efficient at what we do. Here, this is what we specialize in.
I have 2 friends that underwent the procedure, and they both spoke very highly of the procedure, and so from that standpoint, I really questioned them a lot. Like, were there any side effects? Did you, how was your sexual function afterwards? And I asked them a lot of questions that made me feel very comfortable.
I got in, they prepped me, gave me some Valium, I believe. I was like, okay, I'm not as antsy right now, but they did the IV. Doctor came in, we talked a little bit. He kind of went over what was about to happen. We went into the procedure room. He said, this is what's going to happen. This is how it's going to go. We're going to show you actually what we're doing on the screen while we're doing it. We're going to talk you through it so that you'll be at your highest comfort level.
What number of procedures is this?
This is somewhere between 3,500 and 4,000, somewhere in there, over 10 years. All right, well, we're on our 4th case of the day, so working on our efficiency, trying to do every case as perfectly as possible, but getting these patients out as quickly as possible so they can get back to their lives and they don't have to be spending their whole day in our building.
During your procedure, you'll always have a nurse in the back with you, and so we'll help keep you comfortable back there, and we also like you to be as involved as possible and be able to watch if you want. So the first thing he'll do is numb you up there in your groin, and once he's done with that, we take it away and we can pull up a TV screen where you can actually watch and see what he sees. Either I or one of the other nurses will explain what you're looking at and kind of walk you through it. I've been compared to, let's see, Vanna White, a Universal Studios tour guide. So I really walk you through it and make it really easy for you to understand. We're going to check he needs it to first, and then the catheter slips down over into the vessel. Okay, and so the wire acts as a guide. He'll usually go in through the right and go up and over to the left side first. So I explain that, I point out where the catheter is and the wire that he uses to guide the catheter. I show all of that to you and make it really easy to understand. So patients tend to really like that. It helps kind of distract you and you're not just staring up at the ceiling. And yeah, so it's really fun. You get to watch the procedure and we'll just monitor your vitals throughout. But again, no pain, so you're pretty nice and relaxed. You get to listen to music with us and we'll crack a few jokes if you're lucky to. After the procedure, once he's done, he just removes his catheters and he'll get you closed up with a little closure device. No stitches involved, and then we'll take you back up front. And usually the hardest part for patients is going to be laying flat for 90 minutes. And so if that's the hardest part, then I think that's pretty easy.
Then I went back to the recovery room for a period of time, maybe 90 minutes. And then my wife came in, we sat there for a while, and then they took the IV out and I left. So it was pretty good.
Hi, so I'm going to start going over some of the discharge information with you before we get you up. After they come back from the procedure, we like to check in on them around every 15 minutes just to check the incision site, also check some vitals, just to make sure they are stable. We also will go over discharge instructions with the patients before they leave. They will have a packet of information that they will go home with. When I do my 1-month follow-up phone calls, I like to check in on the patient to see how they're doing. I always like to check to see how the recovery process was. I always do like to inform them they can still continue to see improvement for the next 2 months because they should see the full effects of this procedure around 3 months.
And most people possibly not go through the procedure because just fear. Coming from that angle, I definitely want people to understand this procedure has been beneficial for me.
Compared to the other procedures that you can have, it is one that comes with the least amount of side effects, the least amount of pain, and it does not prevent you from having anything else done in the future.
I would definitely recommend having it done.
My advice that I would give is definitely call us. You're more than welcome to come into our office.
And I was telling my spouse that, hey, I think this thing is working. She was happy because, you know, when you're going through something like this, then it's affecting everybody around you.
It's a very personal decision, and everyone should be informed and see doctors that do each of the procedures that they're considering. But PAE does offer the advantage of minimal pain, minimal risk, and a quick recovery. Thanks for watching the video. I hope this has been helpful. If you have any other questions that haven't been answered, feel free to reach out to us, and we'd love the opportunity to see you as a patient.
Okay, great. I hope that was helpful to kind of get a feel for what it's like to come in and have the procedure. So at this point, I'll go to the questions that we have. I want to remind or just let people know that if you do have a question, your name won't pop up on the screen or anything like that, so you can ask it anonymously. All right, so I'm going to start kind of with the oldest question, and we'll work our way forward. Here's a question. The steam treatment, which is the Rezūm procedure, widens the urethra. Is that right? Yeah, it does widen the urethra. It does that by destroying prostate tissue. So it does widen the urethra, but really what it's doing is destroying the urethra in that section and destroying part of the prostate and just creating more space in general, which the urine can come through. And that's kind of the general technique of a lot of the procedures or the surgeries for BPH, is to destroy all the stuff in that area to create a larger conduit for the urine to come out. All right, moving on. What are the main things that can go wrong during PAE? Yeah, so, I think the main thing that we worry about is non-target embolization, or sending particles to organs other than the prostate. The one that is most concerning is the penis. And the reason the penis is most concerning is because the other organs like the rectum and the bladder tend to have a lot of different blood supplies. It's very redundant. And so if part of those, a few of those arteries to those organs get blocked, nothing happens, because there's so many redundant blood supplies. It just brings blood in from other ways. But the penis is different. And so, that's the main one. So like I spoke about earlier, that's one of the main skills of this procedure is knowing how to watch the particles when they're injected to make sure that they're not flowing down to the penis. What else could go wrong? Sometimes people come in and they have, this is rare, but they have a lot of plaque or disease in their arteries, like atherosclerotic disease and calcium plaques. And when that happens, sometimes we can't navigate the catheter where we need it to get to do the procedure. And so there are occasions, rarely, that we have to stop the procedure because we can't get the catheter where it needs to go. All right, how long does the procedure take? It usually takes between 30 and 45 minutes is what's most typical. And that's kind of dependent upon the anatomy, and everybody has different anatomy. Some of the patients ask me, well, isn't it the same procedure every time? No, it's really different. Everyone, I describe it as everyone's a snowflake, in that sense, that the twists and turns and the angles are all different in every person. And so for some people, it's going to be very easy to manipulate the catheter where it needs to go and then inject the beads. And other people, it's going to take longer, and we might have to open some different devices, different tools to get to the right spot. And so in those cases, the procedure takes a little longer, but for the most part, it's 30 to 45 minutes. Has any practitioner of this procedure ever plugged up the wrong artery? Yes, absolutely. There's been case reports of all sorts of different things getting plugged up, whether it's the penis like we talked about, or the rectum, or the bladder. So yes, it has happened, and it's possible, and that's why as the person doing your procedure, I need to be very familiar with the anatomy and know how to avoid those things from happening. What's the impact to ED? Neutral, could it make it worse or make it better? It's actually neutral. It doesn't make it worse, and it doesn't make it better. The only thing that could potentially make it better is sometimes the medications that men take for BPH can worsen their ED. And so by stopping those medications after a PAE, sometimes erectile function improves. But the procedure itself doesn't change it one way or the other. How do you know that the material stays in the prostate and does not escape into the bloodstream? All right, so this is a question of plumbing, of how the plumbing in the body works. There's arteries that take blood to tissue or to organs, and the blood flow carries it. It's like a current down the river. the blood will flow downstream in these arteries, and the arteries will continue to get smaller and smaller. And so eventually what happens is the little particles get to a place where the arteries are so small they can't advance. And when they're in that position, the blood is pushing behind them, so they're needing to move forward downstream, but the artery is too small for them to go, so they get lodged there, they get stuck. And so that's why they can't escape. It's just how the plumbing works in the body. What percentage of men have reduced ejaculate after the procedure? That's a good question. I don't know that we have a number from research. I can tell you what it is from my experience. I would say it's probably in somewhere around 10% or so that actually say that volume is reduced. One thing to note is that the function of the prostate. So people ask me, what does the prostate do? The function of the prostate is to create fluid that nourishes the sperm and allows the sperm to function normally and swim as they should. And so that's why you can have your prostate taken out later in life when you no longer want to be fertile, and it won't affect, you can still function normally. Now, people say, well, I've always heard that when your prostate is removed, you get sexual problems, you get erectile dysfunction, and that is true to some degree, but that's not from removing the prostate. That's from the surgery. That's from the actual removing it. It's not the fact that the prostate is not there. The surgery has some kind of, collateral damage sometimes. So back to the question, if that's what the prostate does, it creates this fluid, and we're shrinking the prostate down, the glands of the prostate, then there is going to be some reduction in the fluid that is being produced. Whether it's noticeable or not, that's a different story. But that's why that happens. All right, any wait time required for getting another procedure such as a hip replacement, shoulder replacement? No, there really isn't. I think once you get through the first week, just so we can get our medications, done, and all the medications we prescribe are done after a week. I think after that, you can go ahead and get those procedures. And in fact, I hear a lot of stories of men who undergo knee replacement or hip replacement, and because of the anesthesia, if they already have an enlarged prostate, when they come out of those surgeries, some of them can't urinate at all, and they have to go home with catheters. And so it's good if you're thinking about having one of those procedures to have something to treat your prostate first, so you're not at risk of being in retention and needing a catheter when you come out of anesthesia from a joint replacement. All right, compare the side effects of the different procedures and the advantages and disadvantages. Okay, so that's kind of a big question, but I'll give you an overview. And I want to preface this by saying that I don't do those other procedures that are the urologic procedures. So a lot of the procedures are transurethral, meaning they go through the penis, like we talked about. The gold standard procedure, which we didn't mention, is called TURP, or TURP, or some people call it the Roto-Rooter procedure. And that one's been done for maybe about 50 years now. And you take an instrument and go through the penis and basically Roto-Rooter out a channel. That procedure is very effective in improving urination, but most patients will not be able to ejaculate after that procedure. So the main issues that tend to go along with some of the procedures that go through the penis are sexual dysfunction, or potentially bleeding and prolonged hospital stay. However, some of them are minimally invasive, like the Rezūm procedure. That's the steam. That does not happen in a hospital, and that has less sexual side effects. It tends to be more painful than what we do, and it lasts the same amount of time, so there's not a lot of advantage to it. The Urolift, similarly, more painful than what we do and doesn't last any longer. So I don't think there's a lot of advantage to that over a PAE per se. The aquablation does last longer than what we do. It does carry more side effects, more sexual side effects, and potential bleeding side effects than what we do. And so that's something to consider. So that's kind of an overview that basically, as you go from lesser invasive to more invasive, you have more potential long-term side effects. And PAE is the least invasive of all the procedures available. All right, how severe do the BPH symptoms have to be in order to be eligible for the procedure? Not too severe if it's something that bothers you, or if you're taking medication for BPH and your goal is to not take medication anymore, then I think that's a good reason to do the procedure. We have some patients who come in that have really minimal symptoms because they're taking medication, but they just don't want to be on those medications for the rest of their life. And so we do the procedure to kind of, for the sole purpose of getting them off the medications so that they can move forward without the medications. Can the procedure be done after Urolift? Absolutely. We see a lot of patients who've had Urolift already that have a PAE, and it works just as well as patients who have not had a Urolift. Can this procedure be used to treat prostate cancer? A good question. So the answer is no. We don't use this procedure to treat prostate cancer. However, we do know that the effect of the procedure on patients who do have prostate cancer, what it does is it reduces the number of cancer cells in the prostate. It doesn't eliminate the cancer, and that's why it's not used as a treatment. If it eliminated, we could use it, but it just reduces the number of cells. So if a patient has cancer, we can still do a PAE, not to treat the cancer, to help with urinary symptoms, but it is not a treatment for cancer. The other thing that I'll mention is sometimes a PAE is helpful before a patient undergoes radiation therapy for cancer, because by reducing the size of the prostate, we do two things. One is we make the amount of radiation required to treat the cancer much less, and two, we reduce the chance that after radiation there's going to be bad urinary symptoms. And so that's another kind of application of the procedure to help in that population. All right, how do outcomes and durability of PAE compare to the other treatments you discussed? So I mentioned it a little bit, but I'll mention it again. When we look at Urolift and Rezūm, they have about the same durability that PAE, meaning they last about 5 years. When you look at procedures like aquablation or TURP or HOLEP, if anyone knows about those will last longer than PAE, but also carry more potential serious side effects than PAE. All right. Can the particles get away to other areas after they were inserted? How is that prevented rather? Can they? Yes, they can. It's prevented by knowing the anatomy very well and injecting the particles in places that it's safe to inject them. And that just comes down to the knowledge of the person doing the procedure and using the X-ray to visualize things as well as possible. Yeah, so that's how it's prevented by our knowledge of doing this, thousands of times. Do the Urolift devices remain in place, or will they need to be removed? For the most part, they stay in place. Very rarely they'll cause a problem where they poke out or something and need to be removed, but for the most part, once you have them in, they're staying in for life. Will the procedure change my PSA number afterwards? Absolutely, that's a great question. The procedure does reduce the PSA usually by about 60%. So after the procedure, you will, so you don't want to check a PSA for the first 3 months after the procedure, because it may be super high because the prostate is inflamed. But after that 3-month period, if you recheck a PSA, it should be about 60% of what it was before the procedure. All right, what is the particles material? Do they stay there forever or they dissolve over time? Okay, good question. So the particles that we use currently are made of something called polymethyl methacrylate. It's a synthetic substance that is used in a lot of implants in the body because it's inert. It doesn't react to the tissue. So the ones that we use are permanent. They don't dissolve, so they will be there forever. But this particular particle that we use for this was used for other things prior to PAE, so it's been around for 25 years, and so we have long-term follow-up on patients who've received this particle, and we haven't seen any issues with it. Any issue if I'm a diabetic controlled by insulin pump or Dex? Not at all. No, I've had patients come with Dexcoms. That's not an issue. The only thing that we'll warn you about is we do use steroids to help treat afterwards, to treat the inflammation, and obviously that's going to bump your blood sugar. But if you have a pump, then you'll just get more insulin, and that'll be fine. So that's not an issue at all. All right, I understand that the success rate of PA is about 85%. Yes, that is true. So I apologize if I failed to mention that earlier. It is about 85% effective. That means 15% of patients that have this procedure will not get the outcome that they're hoping for. And that's hard, but then we just redirect those patients to something else and make sure they get treated with something else. As the prostate gets bigger, the efficacy rate actually goes up, believe it or not. So if your prostate is up there around 80 grams or so or above, then I would say the efficacy rate is more like 90%. But yeah, it's important to realize that this is not 100%, that there will be patients that do not get the result they're looking for. Are prostate cancer patients eligible for the procedure? Absolutely, as long as we're treating enlarged prostate and not treating cancer. All right, what procedure produces the biggest reduction in the prostate? Well, that's a good question. The answer is prostatectomy. That's removing the prostate altogether. That's how you're gonna, if you really want your prostate to not be there anymore, you can have it removed surgically. After that, I would say there's a procedure called HOLEP, which is an acronym that stands for holmium laser enucleation of the prostate. And that basically scoops the whole prostate out through the penis. And that would be the next one that would reduce the most. And then after that would be aquablation. All right, I have not explored the medication route. Do I need to do that before PAE? No, it's not a necessity. If you do not want to try the medications and there are reasons to not do it, there are side effects to those medications, then you can have a PAE without having taken medications. Who is the most male potential candidate? Who is the most male? Well, I don't know what makes people the most male, but I think maybe the question is who's the best potential candidate? And I would say we do the best with patients who have prostates that are around 50 grams or above, who have symptoms from their prostate, although I will reiterate that, again, we talked about earlier, you may not have symptoms if you're on a medication. We also do this procedure for patients that have smaller prostates than 50 grams, but the chances of success are lower, and I tell that to patients before we do the procedure. Okay, how severe do my symptoms need to be before deciding to do something about it or just live with it? I'm almost 79. So this is something that a lot of men ask me also. Can I just wait? What if I just wait? So I will warn patients to not do this. And the reason is that I've seen too many patients in this situation that wait, and then eventually they just can't urinate at all. They wake up one day and they can't go, and all of a sudden they're going to the emergency room to get a catheter. And that's certainly unpleasant, but that's not the worst part of it. The worst part of it is at that point, the bladder has gotten so weak from pushing against obstruction that now it's much harder to get someone back to a semi-normal kind of urination. That once the bladder weakens, it can be rehabilitated, but it takes longer and it's harder to do. So I try to encourage patients, do this earlier than later. When your bladder is still, pretty healthy, you'll get a much better result, and you'll avoid longer term problems too. All right, how long does cutting off the blood flow take to see significant improvement in urine flow? Yeah, so usually you'll see an improvement anywhere around 2 to 3 weeks is when people will start to see improvement, and then it will progress over 3 months. Where do I practice? So on this slide, you can see I practice at IR centers. It's located in Briar Creek by the airport here, and there's our contact information on the slide there. Please describe the vascular closure device. Is it dissolved or is it permanent? Yeah, good question. The vascular closure device that we use is called AngioSeal, and what it does is it places a collagen plug on top of the hole that we make in the artery, and there's a little foot plate that actually goes inside the artery that holds that plug in place. All of the components do dissolve over time, so none of it is permanent. It stays long enough to make sure that that hole heals up as it should, and then it dissolves. With an average span of 5 years for effectiveness, is there a limit to how many times it can be repeated? I think there is a limit. The most I've done for anyone is about 4 times, but I think you can get longer. I think if the span of the effectiveness tends to increase as you have it done, again, because we're taking out more of the possible routes that the blood can be rerouted afterwards. I didn't mention why. I think I didn't mention why it doesn't last forever. So the reason is because what the body does is it grows new arteries over time. And so when you block blood flow, basically new arteries are growing to create detours around those blockages. And so that's why the prostate keeps getting blood and starts to grow again. And so that's what happens. But as you do it more and more, I think you block a lot of those and you can get longer time. But the most I've done it for anyone is 4 times. How often do you see 3 prostatic arteries bilaterally? Does that make the procedure more difficult? Yeah, it happens occasionally that we see more than one artery on each side that's supplying the prostate, and it does make it more difficult because you have to catheterize more arteries. But how often? It's pretty rare. I mean, I would say it's somewhere around 1 in 20 or 5% or so that have more than one artery on each side. At what point is PAE advised if a patient is currently taking meds for VPH? So I talked about this a little bit earlier, but I would say the sooner the better. That would be my recommendation. Likelihood of needing a catheter inserted due to bleeding. I had an aquablation about 5 years ago and 4 years earlier, Urolift. Oh, you're a veteran. You've been through some of these. In our case, it's very rare that a patient needs a catheter, especially due to bleeding. It's not, we're not because we're not cutting anything, or we don't, we can have bleeding afterwards, but it's not that common. It can happen occasionally that the prostate gets inflamed enough after the procedure that the patient can't urinate. It's not common. It's rare, but it can happen. That's the reason that patients might need a catheter. Usually in those situations, the patient has needed a catheter before that, and so they're on the brink of being in retention. And so the inflammation that we cause can put the patient over the edge a little bit and require a catheter. But I would say rare, something like 1 in 30 to 50 patients. It doesn't happen very often. All right, iTind versus PA. So iTind, for anyone who's not familiar with that, is a stent that gets put in the urethra and then removed, and it basically causes the urethra to expand, and then eventually it gets taken out. In my experience, and again, I don't do iTind, I just kind of know from talking to patients and doctors about it. iTind tends to be most effective in smaller type prostates. So even though they're enlarged, they're only minimally enlarged, and it's somewhere in the 30 to 40 type gram range. And so that's when I think iTind tends to work pretty well, whereas PA doesn't work as well in that range, although it can be done. And so I think that's kind of the difference. They're both minimally invasive procedures with less pain and less destruction of tissue. But I think for larger prostates, PAE is the way to go. Do you determine the size of the prostate before doing the procedure? Most of the time, I don't personally do it. Most of the time, the urologists do it before they send patients to me. So they'll do either an ultrasound or an MRI or something, and we'll know the size of the prostate. Another way to have a sense of the size of the prostate, even if we haven't done imaging, is to look at the PSA. So when you have a higher PSA, say over 2 or so, you can expect the prostate to be quite large. Now, PSA can be elevated either from enlarged prostate or cancer. The difference is in the setting of cancer, it's going to be continuing to get higher and higher over time, the PSA. Whereas when you have a large prostate, it'll be pretty consistent over time. It'll just be elevated. And so if you have a larger prostate, if you have a PSA of 1.5, 2, above that, we know your prostate's pretty big coming in. But again, most patients do get the size of their prostate measured before the procedure. All right, last question, it looks like. I'm less than a mile from you and walk 2 miles a day. Can I walk home after the procedure? Yeah, I haven't had that question yet. That's a new one for me. Absolutely. If you want to walk home, I would just take it easy. Don't walk too quickly, but yeah, you could walk home after the procedure by all means. Okay, I think we've kind of gotten through all the questions here, and it's nice. We're just about an hour. So I want to thank everyone for joining. And again, if you have any further questions, you can reach out to our center here at the number there, and I'll be glad to talk to you about it. So thanks again, and have a good evening.